the building part, the guidance documents are the building blocks that give the detail of what goes into the required policies and the requirements of the law. So there is a compulsion to have proper infection prevention and control. We have the Healthcare Commission, which will soon become the Care Quality Commission, to monitor this and to inspect against it. So there is a strong measure of compulsion there. We do not believe that you tell everybody across the whole country exactly what to do letter by letter, because they are in different circumstances with different infrastructures and different types of hospital, different patient groups. So they have to use what's there to apply to their own setting.
Yeah.
Sorry.
If I may have a comment from the Dutch view on that, I do not care how you call that. That's the definition of the word, as long as it's become the professional standard. If it's by legal force, by peer force, by governmental force, I don't care, but I'm agreeing with you that you should have one professional standard. And this is the first disagreement, finally. After you might have thought we talked before and we arranged we have the same. I do agree with you, gentlemen, that yes, you should have the same standard all over the country. Because if you lower the standard right away or allow them to keep out, they will never build the isolation room. They will never get the extra thing. So yes, there should be some basic standards that are the same for every hospital setting.
The code of practice is for the whole country.
Yeah. Final question, please, because we have the masterclass about to start here. Final question? Yes, in the front.
It's a question for Brian Duerden, Ground Tanner for National Concern for Healthcare Infections. Brian, we accept the mandatory surveillance, the figures have fallen for particularly Clostridium difficile. But if you sub-analyse those particular figures, you find that the community side has actually increased. And in some cases, some individual trust, the community or non-acute side can be as much as 70% of the cases analysed. Is there a way, or is there any proposals coming forward for a fully integrated healthcare policy for both healthcare and social care, which will actually move to eradicate this problem?
Yes, because this is a problem that doesn't just apply to acute trusts, it does across the whole health and social care sector. That's why the targets for reduction of Clostridium difficile infection actually were set at PCT level for their population, not just at the hospital level. It's not the general population at risk. These non-acute hospital cases generally have a lot of links with healthcare, with other healthcare settings. So it's getting that whole package together. And that's the aim of the new Health Act 2008, the revised code of practice that applies to hospitals and other healthcare settings and social care settings to bring all this together.
Jonathan, just in 5 seconds flat, do you have plans to miniaturize technology for use in primary care or community settings?
Not specifically, although where we are right now is that the links between primary care and hospital settings are becoming so close that the discussion is almost a joint one.